Thank you very much, Nikos. From my side, I have to thank you for the invitation, Dr. Sumelis and Olga Savidu. So I'm going to talk to you about complications. Of course, I don't want to go, it's kind of boring to go through the whole literature. So I'm going to give you some tips to avoid them as well. So I have no conflicts of interest. The indications, more or less, we know them. Maybe the past years we've learned to maybe treat, as we heard from Nikos as well, fractures as well, and at the same time, what I do actually, instabilities, without opening up and doing some open surgery. That contraindications, we've heard already. I have to say, I don't really agree with transposition. That's why, because we can kind of find out where the nerve is and actually proceed with the arthroscopy as well. So the complications that we see most of the time are, of course, as we see, your 2.5% postoperative neurological injuries. As we see, it's a systematic review, a new one actually, from 2022 from Tenkov and Dimitrov. That was from the SICA Journal, International Orthopedics. They're talking about 1.26 to 7.5%. Most of them are transient, according to Stetson. And the nerve that is mostly affected is the ulnar nerve, 38%, 22% radial nerve, 19% the PIN. I have to say, what I'm scared of most of the time is the PIN, especially when I do the arthrolysis, not much the ulnar nerve. And if we see all the other arthroscopies, the complication in elbow is 10% more than all the other, like knee and shoulders. So I found a systematic review that was talking about, it was some years ago, 2% of superficial infections. That was, though, if you see, associated with an intraoperative cortisone injection, steroid injections. And at the same time, 0.7 deep infections. I have to say, it's much less, at least my experience, and I do quite a lot, 70 to 80 a year, and I've just had this one infection, it was a superficial one. And the one what we see most of the time is stiffness. Yes, associated with arthritis and disc cancer, as we heard already today. But all the articles that we see, the systematic reviews, they're short-term results, mostly at 6 weeks. And as we know, especially with instability, when we treat something arthroscopically, they get a brace afterwards. So what that means, 6 weeks they get a brace, 4 weeks it's limited, and then it's free. So we see that especially extension and flexion, we see that they get some more flexion and extension after 6 weeks. And of course, heterotopic ossification, but it's quite rare as well. So what do we need to do in order to avoid this kind of things? We have to start already with instrumentation. We heard already from Nikos in the beginning, our pressure, our pump pressure has to be as low as possible, 30 to 40 millimeters of mercury, or even use gravity. The setup, the positioning is really important. Why? Because we don't want to lose time. So that's why, as you see here in lateral decubitus, what I do, of course, you can do prone position and stuff. You have to bring the patient to the front. Why to the front? So especially on the medial side, you can work a bit easier, so you don't get stuck. You don't have any obstacles. And when you move either your camera, your arthroscope, or your shaver, that means you're increasing the time, and the joint is swelling up. The bony landmarks, you start always with this. It's really important, and as you see here, the ulnar nerve has to be really obvious, even during the procedure. So when we begin, of course, we mark the anatomic landmarks, and it's really important to palpate, as you see here, to palpate the ulnar nerve. Why? Because we heard, I think it was Nikos again, where we get a subluxation of the ulnar nerve. We see it quite a lot, so we have to be careful because we're going to do the anteromedial portal afterwards, so we have to know where the ulnar nerve is. We fill up the joint with 20 ml, because I start on the posterior side. As you see, I do 15 on the soft spot and the rest 5 on the olecranon fossa. And of course, it's really easy to stay. Afterwards, I'm going to show you in a bone. Of course, dry arthroscopy is really in. I've started with it as well. Anteriorly is no problem, but at posterior side, all the soft tissue is actually coming to your, it actually obstructs your view. So portal placement, in the beginning, when you start, it's better if you start anteriorly. Why anteriorly? Because at the end of the day, if you need a bit more, the joint is not going to collapse. Of course, I start posteriorly, and if you do that, just do bigger portals. Do bigger portals, and as you see here, stay on the bone, the lateral side, and you go directly to the olecranon fossa. Of course, I go to the ulnar gutter afterwards, but yeah, you have to do a couple before you do that. So when you establish your tricipital portal to clean up your olecranon fossa, you start with your shaver, because sometimes you have to start blind, facing the lateral side, facing your arthroscope. You see that one, you see the monitor there. You face to your side, and do not use that much. Maybe in the beginning, don't use any suction at all. Yeah, because otherwise, you actually suck the nerve as well towards your shaver. But you're actually quite safe if it faces your side, the lateral side. So we start, then next step, anterior medial portal. So we go in front of the intramuscular septum, and as you see here, you go directly to the bone, to the humerus. And then you do a click, and you go up front, and you slide. I go first, as you see my scissors, and the joint is in that way, like further distally. So I do it a couple of times in order to, from normal life. If you do it, go in and out a couple of times, it's easier to get in. But you stay on the bone. You aim the bone. And we've heard it from Koukos again, the high anterolateral portal. Why? Because we don't want to have any injury of the PI nerve, the radial nerve. Or you can do, of course, the outside in or inside out technique. But what I do, I aim the capitulum. Can we play this again? Yeah. So I aim the capitulum, like exactly above the capitulum, because most of the time the one we do, the procedure we do is ECRB debridement. So I save some time, but just coming with my scalpel, you see there, and I've done the ECRB debridement, and I'm safe. So in conclusion, always stay out of trouble. Follow what I said till now. No steroid injections. Don't do it at any joints, actually, after the operation. And mark your anatomic, your bony landmarks. Of course, the ulnar nerve as well. You have to palpate it. And use low pressure, as low as you can. And bone is your friend. Stay on the bone. Thank you very much.